everybody to the first cafe of the season. This is really thrilling to be back. Woo! I want to especially thank this guy, Nick Kern, who owns this bar and grill and gives it to us for this evening. It's really wonderful. Big. And also the staff down there, and others, the cook. Thank you, everybody. It's really awesome. They're closed otherwise on Tuesday nights, so that they open and bring in a whole crowd and try and feed us all at once. It's complicated. It's not that easy. So thank you so much. And please drink and eat and drink and eat, because that helps us repay them. And I also want to reiterate again, if you can't hear the speaker, you should really say something, because that's what you're here for. There is a video that will appear on our website if you want to look at it again later. I want to mention a little bit about science cafes. Anybody here for the first time? Our two speakers. Okay, yes, Michael, our next speaker. I'm just going to pause right now and say that we're going to, next time, we meet monthly. It's usually the first Tuesday of the month, but sometimes, like after Labor Day is the 2nd. We're definitely not going to meet on Election Day. You know, and anyways, usually otherwise the 1st of the month. So the 1st of October, we've got Dr. Michael, is it Wyand? He's CEO of Boston-based Oxia Biopharmaceuticals, talking about clinical trials for concussion. We planned this as a joint sort of show with tonight, because tonight's research, mostly CTE, and Michael Oxia has a concussion drug that is showing promising results in phase 2 human trials. He'll tell us something about the challenge of approaching FDA approval. So about science cafes, they exist here around the world, and there are really a lot at this point in America. It's quite amazing. There's a real blossoming of them in this country, but you can find them in England, Pakistan, you name it. Some stick to one subject, like climate change or archaeology. Our science cafe tries to take in a lot of different subjects. We never have to reach far for interesting people, speakers. One main criterion for science cafes is to do without the screen or PowerPoint. That it operates on the idea the more direct discussion ensues between speaker and audience. There's much more value in speaking directly together rather than getting caught up in the screen. So I'm not moderating tonight. It sounds like I am. I want to pass the mic over to Gail Davidson. Gail is the wife of Tom Gidwitz, and Tom was a true jewel of a science writer. He helped start the Science Cafe over 7 years ago, and then in 2018, Tom arranged for 2 researchers from BU's CTE Center to speak on the topic of youth football and repetitive brain trauma in young athletes. It was a real eye-opening evening, but then right after that, Tom learned he had acute myeloid leukemia, and we lost him 2 years later. So when we were planning tonight, I really couldn't help but think of Tom so much and have someone back who was so close to him. So I asked Gail to serve tonight as moderator. Gail is a doctor in her own right with 44 years of experience in the medical field, so we're in good hands. And onward to Gail. Thank you.
That was a really nice introduction to me. Anyway, thanks, Anne. So I cannot remember much about the details of the last lecture, but it seems to me we talked a lot about structure of football helmets. And things have come a long way since then. So that if you think about concussion, you know, we all thought about Muhammad Ali. That's who I grew up with, and the sad spectacle of him growing older and more infirm. But when you think about concussions, it's a black hole. You know, somebody gets hit, they get a brain injury, and maybe they get a bruise. Maybe the brain liquefies. We don't really know, but it's becoming more and more clear what the actual problems are. And therefore, if you know what the actual problems are, you can think about what you can do about it. Hence, the chronic traumatic encephalopathy unit at BU and these two lovely women. So, Megan Ryder does a lot of the interviewing of the patients who come into the center to try and get the details of their concussion exposures. And I guess then they can put them into a database and get some information from that. And Liz, I gather, is doing some molecular work in the lab. And who knew that there was molecular work to be done in the lab for brain injury? So thank you very much for coming. And I just want to say one quick thing about science writers, because they were asking me about them earlier. And my husband was a writer who wasn't a science writer, and he just sort of happened into it. And they did a survey of the New England science writers long, long ago. And everybody in the Science Writers Association thought that a science education would be a great idea. 99% said that. And 99% of the science writers did not have a science education. They came from liberal arts. So here you go. Thank you.
Thank you, Gail. Thank you all so much for having the both of us, and thank you to Anne and Gail for such a wonderful introduction. I know we're both excited to be here and to have a discussion about CTE with you all. Yep.
Is this close enough?
Yes. There we go.
Right. Hi, my name is Megan, and I work on the clinical team at the CTE Center.
And my name is Liz, and I'm a research specialist and our tissue request coordinator on the pathology side of our team. Even closer. There we go. I'll eat it.
I already had dinner, but I'll have dessert, I guess. All right, so the goal of this talk today is to educate you all on CTE, one, why it's important, what it is, and the implications on behavioral health among vulnerable groups that we see typically in the center. And I'd just like to thank Gail and her husband Tom for bringing us here in the first place, and we're happy to follow up on the legacy here. So just to give an overall definition of what CTE is, it's pathologically a tau protein accumulation around the depths or folds of the sulci in the cortex of the brain. So these are the nooks and crannies around the outside of the brain, as well as around the perivascular tissue, so around blood vessels in the brain. And the reason why these are targeted is because they're mechanically weak regions of the brain itself. So when subjected to mechanical blunt force trauma or mechanical force through blast blow exposure, we tend to see that these regions are typically impacted first in the brain itself. So like other tauopathies, such as Alzheimer's disease, this abnormal tau starts to clump up and it spreads in the brain. And Liz, who is our pathology specialist, will talk all about how that happens and how we look at it in the lab. But mainly I want to highlight that we characterize CTE lesions differently than other neurodegenerative diseases because of the mechanism behind in which they are caused. And this is through something called repetitive head impacts. And repetitive head impacts are typically repetitive, not to be redundant, but they're repetitive, means of exposure to blunt force trauma. This could be through contact sport play. This could be through military training, blast blow exposure, artillery firing in the military, It also could be due to physical violence in any form, such as domestic violence, intimate partner violence, boxing, kind of falls into the realm of contact sports as well. So we see a lot of overlap and even see CTE in horse jockeys and rodeo clowns, stunt doubles, things like that. So really unique forms of exposure that all have an underlying ideology of repetitive blows to the head that are non-concussive or concussive. And there's a big difference between traumatic brain injury itself and the neurodegenerative chronic aspect of CTE, which Liz will go into now.
Great, thank you so much, Megan. We wanted to specifically differentiate TBI from CTE, given you will be hearing about TBI next month. So traumatic brain injury, given it's a trauma, that's referring to a really acute injury, whereas CTE is a chronic, progressive disease that we study. So we really want to make sure that there's an understanding that TBI and CTE are not the same thing, and they present very differently. And TBIs are something that you usually see recovery from within about 7 to 10 days, whereas CTE is a progressive neurodegenerative disease that you see getting worse and worse over time. And with that, we'd like to give you a little bit of history on CTE and how we got where we are today.
All right, so see, defining CTE and its origin points is a little hard because it was named differently in the beginning. The first documented pathological publishing of what we now know as CTE was called Dementia Pugilistica in 1928, and this was by a researcher, Dr. Martland, who first studied boxers. And so as Gail or Ann mentioned about Muhammad Ali, we see in boxers that punch-drunk or Parkinsonian-esque manifestation of clinical symptoms that started from their boxing careers. And this is something that was unlike any other dementia that people had seen before. So of course, even as early as 1928, they were very curious about what this meant and why it was so different than something like Alzheimer's disease or Lewy body disease. And then from there on, there was some research that would say made some nominal jumps, but a big breaking point thereafter was Dr. Bennett Amalu, who I'm sure you may have heard of from the movie Concussion, who studied the first NFL player in the National Football League, professional football, and he autopsied the brain of a former famous NFL player, Mike Webster, and found that he had CTE, and it was that pathognomonic lesion of tau at the depth of the soul side that we mentioned beforehand. And so our lovely role model and our principal investigator at our lab, Dr. Ann McKee, she took that information and ran with it. And she started the CTE Center in 2008. And Liz works very closely with her, and I'd love for her to talk more about that.
Wonderful, thank you. I'm fortunate enough to work at our Bedford VA location, which is where the CTE Center actually started. And it was really humbling to go back and see the one little closet that Dr. McKee used to keep the brain tissue in when it was so small and new and exciting. And it's amazing to think that now CTE is something that's internationally studied. And in our Unite cohort alone, which is those athletes and RHI exposed brains, we have over 1,500 brains in that bank alone. But what's interesting to me is we study much more beyond that. The CTE Center really is an umbrella for 7 different brain banks. So this is just one of our big initiatives, but it's been really incredible to be a part of that team and to see it grow over the years. It's now regarded as the largest brain bank in the world for studying traumatic brain injury, and we're making a lot of progress, and we're excited for our ongoing research and what's to come.
And something in the progress of this timeline that we're presenting you that's also notable is once we started to accumulate enough brains, which sounds kind of creepy, but had a very specific process that's started in 2015. We founded our brain bank, where we'd have people call a pager line, or we would hunt down medical examiners to acquire certain brains, to examine them. It was really scrappy in the beginning, but soon people started hearing about our work and decided to donate to us. And by 2017, we had over 100 NFL players that had had their brains donated to us, and we studied all of those in a convenience sample study. And we found that 110 out of 111, which is 99% of the NFL brains studied, had CTE, which is incredibly profound, and also we can demark to selection bias, who's choosing to donate the brain, of course, right? So, all of that comes with an asterisk, but by 2023, we've had over 375 brains that were former professional NFL players. That prevalence dropped to 90%, which is still pretty incredible. So again, selection bias is a thing. There's a reason why people donate, and we'll definitely go into that more. But it is profound to compare it to different population cohort studies, such as the Framingham Heart Study that we work very closely with, who has a prevalence of CTE of 1.6%. So it's typically, if you're playing up to high school, if you're living in a higher socioeconomic class, and you have these protective factors that we still have yet to study as much as we want to, there's a certain prevalence drop than compared to people that play at higher level. Okay, so sorry, I'm going to talk on it for a second. So now we're going to talk about our protocol, kind of how we get the brain from someone's head to Liz's hands and this model here. No. But yeah, so first and foremost, I just want to describe my role. I am the Unite, so the study's called Unite, and I'm the pager coordinator. So I'm the one that is running all the brain donation requests that come in, and this is quite literally on an iPhone with Tom Brady holding the Lombardi trophy, but it's a brain that's replaced with the trophy itself. And so we get a call on that number, and it's a family member, it's a medical examiner, it's a funeral home director, and they're saying, listen, we have this person and we think they'd be valuable to your research. Or we have this person that wanted to donate their brain and that was their dying wish. And so obviously we take that with great gratitude and grace, and we will, within the means of an adequate 72-hour post-mortem interval, will try to take their brain. And we do this by working with medical examiners. We work with the funeral home directors and have a nationwide network of Deaners that come in. And the Deaners are like autopsy technicians or pathologists that are certified in actually doing tissue rescue and safely transporting it to our lab. So this can happen, it happens in all of North America now, but it started just in Massachusetts, and we slowly branched out and made our connections along the way. And so we get a call, we coordinate the tissue rescue, and then we airlift it, or we ship it. It sounds archaic, but we do, to Boston University and to the Bedford, or we have a Jamaica Plain veteran or VA hospital lab. And from there, we communicate with the family along the way. All this consent and legal consent is required, and intake, etc., to get there. But once it gets into Liz's hands, it's out of my control.
Thank you, Megan. So I'll get a little bit into the nitty-gritty about from step one through the diagnosis of what happens to a brain when it gets to the CTE center. It's wonderful to have such an amazing clinical team to communicate with us and help facilitate getting these brains to our lab in really quality condition. They work really hard on those pager calls to make sure that they're coming in a good shape within 72 hours so we can run all of the studies necessary to get a cohesive diagnosis and run all of the experiments that are really pushing the field forward. And one thing that I want to mention is that every time we get a brain, our team views it as a gift. We're really grateful for the opportunity to work on someone's loved one's brain. It truly is remarkable for someone to make that donation and entrust us with their family member like that. And we try to emphasize how much that gift means to us and all that we get to learn from it. And it's really incredible to be a part of that. But once we get the brain, we do an unboxing process and then do our whole big intake. And ideally, we receive the brain fresh, so nothing has been applied to it outside of the rest of the body. And we would get this full brain, and we have to process it immediately. One of my bosses is in the lab 24/7, 365, ready to process these brains when they come in fresh, because as soon as they're out of the body, the tissue starts to die, and we need to preserve as much of that tissue as possible. So as soon as it comes in, we will hemisect or cut the brain in half, and one half will be put into fixative to be used later, and that's what we'll use to make the actual diagnosis for that tissue. And the other half we work with fresh right then. We cut coronal sections from anterior to posterior and put them on plates on dry ice to freeze them immediately. It's amazing. This tissue will freeze in 30 seconds and is ready to be held at -80 degrees Celsius indefinitely. We still have cases from back in the 90s in our freezers. While we're taking those serial sections, we also are pulling out little special areas that make up our special studies. And these are studies that we're looking at DNA and RNA and proteins all in this brain that really help us get a better understanding of potentially any pathology that was going on. Then in about a month, once the other hemisphere has had time to firm up in the fixative, we'll go ahead and process that hemisphere. And that's a really detailed process in which we again serially section the brain from anterior to posterior. And we have a standard set of blocks that we take. Those blocks are about an inch and a half long, and they're very thin. And those sections will then go on to be cut and put on the glass slides and stained to be looked at under the microscope. And something really unique about our operation is the number of blocks that we take. At our traditional medical examiner office, they will get all the clinical information about a case that they receive beforehand, and using that will guide them as to what regions of the brain they sample. And we try to do something different. We stay blinded to any of the clinical information. So while we're over here doing all of our brain processing, Megan and her team are gathering really invaluable clinical data that will help us put the pieces together after we come up with a diagnosis. But being completely blind to that, we have no bias when we're evaluating this tissue, from the gross examination to the microscopy. So those traditional pathologists take only 4 to 6 regions. We take between 38 and 45, and we have the standard set that we take specific to the cohort. But taking this really comprehensive look at the brain, it allows us to get a full picture of the pathologies that they had going on. And it's really evident that this is important because so many times we'll look and the clinical doesn't necessarily match everything that we saw. And that's due to just the comorbidity that we see between things like CTE and AD. So we think it's really important that we take such a careful look at the brain and have the standardized protocol. But after we take all of those regions, we send them up to our lab where they go through some rigorous processing to be prepared into these little blocks that then get cut and mounted onto glass slides. And once those are all stained for different proteins that allow us to visualize that pathology, they get boxed up and sent to one of our neuropathologists for review. And that's how they come up with a diagnosis. All right, and after the diagnosis, we go to what we call a consensus, which I will let Megan talk to you about.
So this is where I come back into play because I don't deal with any of that. She's too smart for me to intervene. So while all that's going on, I'm communicating with the family. We like to involve the family in these processes because legally it's their tissue, and also they have the most invaluable data, which is memories of this person, stories, close contact, of observing their behavior, valuable clinical data that we can't get by looking at the tissue itself. And so what we do is we have this, what we call a retrospective qualitative informant interview. And this is talking to loved ones. This could be teammates, usually family, but everyone has different family situations, friends, and loved ones, spouses, children, etc. It depends on who's coming in. and we talk to them, and it's typically, I like to chat, so sometimes it takes up to 3 hours of just sharing stories and information that covers cognition, behavioral health, motor function, and sleep. And we also review full medical records with them. We request from all the facilities they've ever been to. And we just do this really deep dive that all culminates into what we call a disease progression timeline. And so this timeline is essentially a repository of all their exposure to repetitive head impacts, whatever that may be, and then from the time they were in grade school, what was their baseline, to where did they end up? What were the changes that were occurring in their lifetime, and what could attribute to what could we say caused that, and what do we not know? And so, of course, there's a lot of substance use involved. There's a lot of trauma and post-traumatic stress from various participation in sports and military and domestic violence. So there are some pretty tough conversations that are had, but eventually we present that clinical data to a board of neuropathologists, neurologists, psychiatrists, and neuropsychologists, and that story is used to diagnose someone or practice diagnosing them with something that we call traumatic encephalopathy syndrome, which we'll talk about later, and that's just the in-life diagnosis of what CTE is. And so we try to train clinicians on how to look out for those symptoms, those warning signs in life, and then we essentially guess and check with the pathology that they're working up, because as Liz mentioned, the diagnosing CTE can only happen post-mortem. So we want to talk about advancements.
Following our consensus, there's another really unique thing that our bank does. We do this really robust workup and really try to keep the family involved, because we know that it was likely a traumatic event surrounding their death, and we want to give them as much closure and as much information as possible. So after a diagnosis report is written up, unlike a traditional pathologist who would just send that report on over, one of our neuropathologists personally takes the time to give each family a phone call to discuss that report with them and answer any questions they might have. So this includes, in detail, going over this long report, and then oftentimes they'll have questions about the symptoms they saw them experiencing in life. And this is an opportunity for the neuropathologist to either validate that, yes, those symptoms that you saw, that's consistent with the diagnosis that we saw, the correct pathology, or potentially, no, that's something we can't explain by the pathology we saw, and there may have been something else going on. But we found that this is really sort of a great opportunity for the family to get some closure and to better understand the research that we're doing and the specifics regarding their loved one's brain and the pathology that we found. And as Megan started to mention, we are working hard on some in vivo studies to progress the field forward and learn how to diagnose CTE in life. As currently the gold standard is diagnosing on the post-mortem tissue, which we can only do under the microscope. We can see some physical changes grossly, but we can only sort of, again, guess and check that those are characteristic of CTE. But then we have to look at those slides under the microscope to see the molecular changes. But we're really hopeful that in the future we can transition to having some sort of in vivo marker to diagnose in life, and hopefully that will allow us to approach some treatment options. But Megan has some great information for you on some of our ongoing in vivo studies.
So there's hope. So as Liz said, it's tragic that we can't tell people that they have CTE. We can't give them any sort of closure in life, that they have something that is a neurodegenerative disease and it's not going to be resolved. Although there are ways that we can hopefully indicate that these are likely occurring in the brain. And one of these things are biomarkers. And as some of you may know, they're neurodegenerative diseases like Alzheimer's disease have specific biomarkers in the cerebrospinal fluid, like amyloid plaque markers. You can test for those to see if that's something that is present. As well as in neuroimaging, you can look at certain tau in neuroimaging scanning and see whether that's present in the brain to help indicate a diagnosis in life and treat accordingly. Well, unfortunately, we don't have any indication of that in CTE, and that's because we don't have an understanding of what specifically the tau is accumulating like, as we do with Alzheimer's disease. So we can't find the right radio tracer to exactly highlight or literally radioactively glow the tau in our brain. So we are looking for ways to find that, and one study that we're doing is in blood, and that will be, it's called the Bank study, and it's actually a remote study where people can go to Quest Diagnostics and send over samples of blood to us, and we're able to run it through our testing and hope that we can collect data on what patterns, what similarities there are, and go through testing in certain biomarkers to see what sticks. And we can, this Bank study is paired with CTE donation, brain donation. So we're able to see, okay, did those people that had certain biomarkers that showed up on our testing have CTE or did they not? And another guess and check way that we're able to presume someone has CTE. Another way is through the neuroimaging studies, as I mentioned. It's called PET scans, and that is where you use the radio tracer. Although we haven't found one that's specific enough to CTE, we see that it holds on to tau, but it's not specific enough. It shows up for Alzheimer's disease and whatnot. So still a lot of work to be done on that, and we have a lot of efforts that we're doing in our lab and moving towards prospective studies, so we don't have to keep collecting brains to find an answer. Although we do think that it's valuable to continue to donate, because using this family health history and the clinical call along with the pathology helps us vet this algorithm to understand traumatic encephalopathy syndrome. And the criteria for that are typically that someone has exposure to repetitive head attacks, and this is all in life. They have exposure to repetitive head attacks. They have some sort of behavioral or neurobehavioral dysregulation. This could be depression, apathy, hopelessness, impulsivity, aggression, and then that further progresses to cognitive or dementia aspect, so short-term memory loss, executive dysfunction, and attentional deficits or cognitive fluctuations. And finally, we want to make sure that no other diseases are being accounted for to describe these symptoms. So we look for, can this be described by a different neurodegenerative disease? And this is called differential diagnosis. So all of that criteria goes into what is known as traumatic encephalopathy syndrome, and that's something that is not yet clinically available as a diagnosis. So if someone says, yeah, I have CTE, don't believe them because they don't know yet. But we can presume using this criteria, and we get closer and closer to being more accurate in describing this in life using those retrospective informant interviews. So with all these symptoms presentation, unfortunately, we do see a lot of donors or donor families that are grieving because they've lost their loved one to suicide, or the donor has prematurely died for various reasons, usually environmental factors such as substance or alcohol use to cope with certain behavioral health symptoms, or they also have a vascular risk, and there's a lot of comorbidities that come into play. But just want to highlight that a lot of the pager work is also grief counseling, and these symptoms are not well described, but they're very important to be sensitive of, and we're trying to understand how to support people more that are dying by suicide and donating their brains to research. Unfortunately, it's something that we see quite often, and we don't want to see it at all. And I hate to hear of the 17-year-old girl that's donating her brain to us, and I don't want to accept it, but I have to. And it's so valuable to understand the early stages of disease, but I'd rather not know that and find a diagnosis in life. So that's kind of where we're at with traumatic encephalopathy syndrome.
It's really nice that we get to work so closely with the Concussion Legacy Foundation to help with that grief counseling and working with families and people in life who are suffering with symptoms. The CLF is really great at putting programs together to allow families to come together and develop support systems. And it's really meaningful for myself and the rest of our team to see them get that support within each other. And it's really amazing to see how, as a group, they kind of all have banded together, and many of them are advocates for the research that we do and to try and prevent these diseases from impacting future generations and to contribute to additional research. We also really value the opportunity to have family members come visit our bank. It seemed to be a good opportunity for these loved ones to understand the care with which we treat their loved ones' brain and their memory. And I think they found it useful to know that when they send us a brain, it's not just a one-time gift that they're giving us. One of my roles at the center is tissue request coordinator, and that means that I'm hearing from labs all around the world even who are doing additional research on CTE and want to use some of the tissue from our bank. So then I go back into our lab and am pulling cases from the 90s to harvest and then send to them. So these brains that we've had for decades are still routinely contributing to new science, and there's still so much we can learn from them. And it really is so valuable that we have this long-lasting bank that can be applied not only in our lab, but in Japan and Korea. We're sending tissue all over to be participating in more studies at once, so we can really accelerate the knowledge that we're gaining on neurodegenerative diseases like this. And again, it's just so meaningful to have families come visit us and recognize the gift that their donation really is and how incredible and important it is to us and the work that we're doing. So we want to say a huge thank you to all of the families who are willing to make that gift of a donation to us, as well as our entire team who help make it possible and allow us to continue to put this research out year after year.
Yeah. Thank you all. Yeah.
It's time for questions. I'll try to listen to the questions and then repeat them for everybody. Go ahead.
Do you have any divers? Diving? Do you have any divers in your study?
Are there any divers?
Like not scuba, but like.
Yeah.
I believe we do have a couple of divers, but I can't confirm if we have diagnosed them. But that is definitely a sport of interest. Yes.
Sorry, I have a question. So do you have enough data that you can use like big data, like AI for lack of better word, analysis on it? Is that part of the statistics that you run on it?
Are you talking about divers in particular or everybody?
No.
Okay. So do they have enough data that you can diagnose?
No, I mean, have you run category, analysis using big data, AI,
Are you using AI?
We are working on some of that we can upload images of the slides that we take, and we're developing some systems to automatically count up the different lesions that we see. So we won't have to do that by hand as much anymore, but we think it's still valuable to look at those slides by hand. But one more thing about your divers, we have the largest population of football players, but it is really valuable when we get other forms of exposure. Another big one that we've been looking into recently is soccer, but without having the same numbers that we do for our American football players, it's hard to have the statistical power to really put out data that's really meaningful. So we try to encourage donations from more diverse exposure histories, as well as women.
Do you want to explain the AI time? Sure.
All right, so we brought a fancy little poster here showing some of our tau pathology. And these are digital images that we've taken of those glass slides. And you can see, these are the best example. You have this, it kind of looks like a little tadpole. That's your cell body here with a projection going out. And that's what we refer to as a neurofibrillary tangle. And the collection of those, actually this is a perfect example because this is a vessel right here. And this is what we're referring to as our perivascular space, that area around the vessel, which is mechanically weak. And that's why we see the accumulation of those proteins there. Our best example of that is if you think about a manhole cover on the street, there's almost always going to be a crack around it because it's having car after car go over it. That's because it's mechanically weak, that circular shape. So we see those proteins accumulating there. And with the new technology we have available, it can pinpoint those specific, we call them NFTs for neurofibrillary tangles, to sort of give us a count of how much pathology we have there.
And
Anybody else?
Gail and
Yeah.
So, in terms of the pathology, the plaques tangles or the amyloid and the tau are also in Alzheimer's. How much is this due to inflammation? It probably all is. And are you seeing more amyloid than tau or more tau than amyloid?
That is a really great question. So we're going to talk a little bit about the role of inflammation in the presence of these pathologies, the tau and the amyloid. That's a really great question because we see so much comorbidity between Alzheimer's and CTE that a lot of times there's overlap, and we have to look at the specific patterns of those pathologies to differentiate the two. And off the top of my head, I don't have a sure answer for you about inflammation. I personally believe that that is a huge influence because of the repetitive nature of these impacts to the brain. It's like if you have one insult and your brain sends one inflammatory response to try to respond to that, but you get hit again, your brain thinks it's not enough. I need to send a larger response to that injury. And if that happens over and over again, eventually that environment is going to be cytotoxic from the inflammatory response. So we do hypothesize that that's a large reason for why you have that accumulation in those specific regions, the depth of sulcus and perivascular. But I'm really excited to see the future of the field diving deeper into potentially biomarkers for that inflammation before the accumulation of those proteins, so we can maybe detect these pathologies earlier.
And just to speak on the amyloid pathology itself, typically in CTE, what we call CTE without comorbid neurodegenerative disease, we typically see sparse or limited amyloid plaques, and that's something that's significant and hopefully an indicator of diagnostic criteria or differences between these different between these different neurodegenerative diseases. That's, again, like Liz said, it's hard when someone's older and they have a bunch of comorbid disease.
Go ahead.
How does the NFL see you? As the enemy? Do they call you fake news? Or are they
Everybody hear that?
excited and want to be a party to the information you have and use it?
Great question.
What's your name?
Lee?
Lee?
Yeah.
Lee? I don't know, but I can answer that very well legally. Oh, yes. Yeah, go ahead, Gail.
Does the NFL see the CTE Center as the enemy?
And I said, Lee, I don't know if I can answer that for you. But I will say that several times we've been able to get in the room with the commissioners, and they now have the NFL Players Association that has something called the 88 plan, which helps give medical insurance to people that are, or the players, former players that are suffering from dementia, usually Alzheimer's. They can't say CTE, they're suffering from it in life, but they can help with Parkinsonian dementia symptoms, hospice care, nursing home facilities, stuff like that. So there also are ongoing lawsuits between the NFL Players Association and the NFL, and we have several people in our board that advise on the committees, like the head and spine committee of the NFL, so we're well integrated. But in terms of accepting that CTE exists, it's hard to for even, of course we believe it, but it's hard to prove it in life. So of course people are going to be skeptical, incorrectly so.
And it might also be too late at that point to be approaching it at the NFL level. You maybe need to be at the high school and middle school level and the Pee Wee sports, making an impact there somehow. But that's not your job. Your job is...
She's speculating on how early you can get started on this. I saw another question up there. The gentleman behind.
I'm just interested in your comments on the recent study from Oxford and Harvard about improved cognitive abilities in people who had concussions in amateur contact sports. Does that make any sense?
Can you repeat the question?
Yeah, so this gentleman's asking about, for us to comment on the Oxford and Harvard studies about improved cognitive ability, is that what it is? After receiving concussions at the amateur level. And I will say, I don't know the patient population exactly that those studies were sampling, but I will say there are several resilience factors that we definitely are trying to accommodate in these analyses, and things like education, socioeconomic status. We can't go as far to say race because that is socially integrated to a certain extent, but we can say that, you know, how active you are, how challenged you are mentally, and how much you choose to continue to do this throughout your life and stay engaged and active has a huge factor, and it's called cognitive reserve. So I don't know exactly, but typically we do see bias in our studies where a lot of these people are really have high cardiovascular activity and are really fit. And so a lot of those numbers will be swayed from a normal distribution of people in a community sample, so that could be a factor as well.
So could you just repeat what the study showed? Because it doesn't make a lot of sense just to hear it initially.
Yeah. The study from Oxford and Harvard showed that people that played amateur football, was it?
I think it was
Rugby, okay, amateur contact sport such as rugby, actually had improved cognition later in life if they had concussions. But what I'm saying is that I don't know the exact parameters of the population, but I will say that cognitive resilience comes into play, where if you're fit, if you are cognitive, or if you're keeping engaged in your work and socially engaged, and you have a high socioeconomic status or the means to live a fruitful and healthy life, those are going to be combating factors against that cognition as well.
There was another question in front of you, and then I'll get to the back later. So go ahead, Mr. Axios.
Okay. Is there an effort to build a cohort of non-athletes? I know it's very difficult because, we're decreasing about obviously very difficult to train, but is there an effort to do that to try to identify the incidents in the non-athlete population?
Did everybody hear the question? Is there any effort to accumulate numbers of people who are not athletes getting concussed as a comparator?
Thank you. We work closely with the Framingham Heart Study, which is an incredible longitudinal study happening in the state of Massachusetts. I believe they're on their third generation of participants, and they're really involved and really passionate about participating in this research. And in recent years, we've added a brain donation program, and they then send those brains to us. So that is what we're using as sort of our control population for people without this RHI exposure to see the prevalence of CTE. And I believe that number is about 1.6% compared to the 90% we're seeing in our current NFL players.
Yes, you?
You said earlier, you talked about whether the rugby thing was turned out to be bigger or not. I mean, it makes a certain amount of sense that the brain can rewire itself in certain situations you have to come to do. Well, one of the things I've heard about with CTE is also brain atrophy. And in what percentage of brains are you seeing that there's actual atrophy?
Yes, so the question is, in what percentage of cases are we seeing atrophy in CTE? Atrophy is one of the signature signs that we see in a brain with CTE. These accumulations of the pathologic proteins, they're really just clumping up and disrupting signaling there, and eventually those cells die off. And when those cells die, you lose brain volume. Because you're having that cortical, the cell body die, and that leads to the axon in the white matter dying off as well. So you'll see atrophy in the same way you would see it in Alzheimer's similarly. It's just a little bit different in terms of it's more of a frontal lobe based disease. So you'll see it impacting the frontal lobe first as opposed to more of the hippocampus in Alzheimer's. But in some of our really young people, which we unfortunately get frequently, you won't see a lot of atrophy, because we don't have a lot of that pathology accumulated yet, which is one of the reasons why we're really, really pushing to understand the earlier changes of CTE, because we imagine there's got to be a way to see them, because there's some change that's causing these different behavioral issues, and that's leading to those traumatic causes of death. But atrophy is absolutely one of the things that we see in CTE.
There were a couple more questions. There, go ahead.
What is the youngest brain that families have donated? Like, do you have any children?
What's the youngest brain they have?
So as far as in the shifts that I've ever done, the youngest brain I've ever accepted was 14, but the youngest I've ever received is 9.
Oh, wow.
And so that could be, astonishingly, they're also dying by suicide, but it's something that is, it's dumbfounding to even begin to process how young and how irreversible of a decision that is for someone that's played 9 years of soccer by the time they're 14. We want to understand what that means. Is there something accelerating that behavioral dysregulation of some sort? What is it? Their social environment is what is going on? We just have no clue.
One of the things I worry about, like, is chronic head traumas in the younger kids,
Mm-hmm.
and some kids are just accident prone, and chronic head traumas.
Yeah.
Right, so we're talking about head trauma in young kids, and that's actually one of the initiatives that the Concussion Legacy Foundation put forth, is to try to delay the onset of contact sport. So in football, they were pushing for only flag football until high school to try to delay the onset and lessen the accumulation of that repetitive head impact in such young people. And while we do receive an unfortunate number of young people, given the chronic progressive nature of CTE, in the cases that we're diagnosing, it's often an older crowd, but we do unfortunately receive a decent number of very young brains.
Thank you.
Okay, in the back.
Yes, you explain how the biomarker data that you collect in terms of accumulation and age of subject helps support or is not yet shown to support the data that you have from the brain examination.
So this question relates to the biomarkers that they're studying, and if it does support or doesn't support, am I right?
Yes, but
Their
it's the age of the subject.
Okay. As it relates to the age of the subject.
So we're early in our prospective studies, and I will say that there are just now coming 2024 papers coming out about the relationship between behavioral health symptoms and fluid biomarkers. We don't, like I said, we don't yet have a biomarker to identify that someone has CTE in their brain when they're alive, but we do see that people with more of this biomarker called NFL, which is not supposed to be that, but it is. They see some change, some increased impulsivity and aggression, and that's really the only finding that we have so far from those data, as much as I'm aware. And that's been published, but we're in the very, very early stages of understanding that dose-dependent relationship, and by dose I mean how many years of RHI they're experiencing in their life before they're accumulating symptoms and presenting symptoms and subsequently passing away.
Let's see, in the back, way back, with the cat at the bar.
I'm wearing my Patriots hat.
Oh no.
A number of Patriots that have been diagnosed with CTE. Most famous is Junior Seau, who committed suicide at age 43. He's a Hall of Famer. Most infamous is Aaron Hernandez. And I was looking him up, and it said he was diagnosed with stage 3 CTE. What's the difference between stage 3 and stage 4?
That is a great question. We're talking about the difference between stage 3 and stage 4 CTEs, specifically in the context of Aaron Hernandez. So CTE staging is based on different anatomical regions. So we call CTE stage 1 and 2 low CTE and 3 and 4 high CTE. And the presence of pathology in the hippocampus is the line between low and high CTE. So given he had stage 3, it means he had pathology in his hippocampus. Stage 4 really just means that it has progressed further into the brain, but given CTE staging is based on location as opposed to volume of pathology, it's not all that indicative of how much pathology we were seeing. You could have one lesion in your frontal cortex and one lesion in your hippocampus, and that jumps you up to a stage 3, or you could have 200 lesions in your frontal cortex and still only be a stage 1 because it's based on the anatomical region.
And for context, Aaron Hernandez is probably the youngest player or the youngest person in our brain bank to have that high stage of CTE, so stage 3.
Okay, let's see, we had some more in the back. Go ahead.
You mentioned earlier in the talk about some seeming protective effects, socioeconomic status or whatever. I just wonder what sort of data you might be gathering so that you can think about how things either positively or negatively impact CTE, like nutrition, cardiovascular fitness, all of that sort of stuff.
So I think the question is, are they accumulating data about protective aspects of the patient's life that might have an impact on their CTE?
So I'm interested in the field of public health, so I think that's why I bring that a lot into my talks. But one thing that we do collect is zip code, which is supposed to indicate obviously your neighborhood, but socioeconomic status. And it's not perfect, but as we've seen with historical redlining in the United States, there are studies that show where you live. It can indicate some sort of health outcomes and also your degree of economic welfare. So we collect that, and then of course we collect demographic data like race and ethnicity. We collect family history, so do they have a history of dementia in their family? Do they have a history of stroke, cardiovascular disease, cancer? And then we also we collect substance use habits. So how many times have you been to rehab? How many times have you had psychiatric hospitalizations? Have you ever abused medication and prescription medication, or used illicit substances to the point of abuse? And so this is all collected by the informant. It's not perfect, but it is really valuable because it gives us a way to see the confounders or mediators in the data that we're collecting and the pathology that we see.
Back here.
I would assume that a lot of your donation process gets started in an emergency room or in a hospital, if not a morgue, if it, is a death to require a hospital. Is everything Does everything go through the organ bank, or are you a separate track? I used to work
I
in
got
an
it.
ER.
Oh,
Yeah.
interesting. All right, so what's your name? Lee. Lee. I remember. Still Lee. Lee asked if we typically see donation requests come through an ER or the hospital, or if we see those come through an organ donation bank, how we transact those donations processes, if you will. So that actually comes through myself and a few other colleagues on the pager team, and this usually the next of kin calls, and they could be anywhere. They could be in Mexico, they could be at their home, they could be at the morgue, they can be, in Timbuktu. So we just collect where they're at, where the decedent is, or where they're going if they've selected a funeral home, or if they're going to the medical examiner's office, and we try to meet them there. And we have a team that's on the ready pretty much everywhere in the United States, which is really fantastic. And they are able to, at their beck and call, it's a really powerful number, they'll pick it up and they'll say, all right, let's procure this brain. And so they'll meet, like I said, they won't meet you at your familial home, but they'll get you safely to a funeral home or the medical examiner's
But
But
it
office.
starts with the survivor.
Contracted with you.
Yes, they're pre-contracted. It starts with the next of kin typically, or if the medical examiner, because the word's got out about our CTE research, they identify this as someone that has adequate exposure to meet our brain bank criteria, then they'll reach out to us. Typically it's the next of kin.
One more thing about that. If you're listed as an organ donor, your brain is not going to be immediately sent to our lab. It has to go through your next of kin. Even if you had pledged during life that you wanted to donate your brain, after your death, you would have had to tell someone your wishes to have the brain then donated to our lab.
Anyone else?
Anyone else? One more? Oh, go ahead.
I'm just interested in talking awful lot about NHL. What about military?
We can't hear you.
Say it again.
What about guys in the military?
No,
the military.
How much do you get? How many brain donations do you get from them, or can you tell? Do you get any support from the Department of Defense or anything like that?
Okay, this is a big subject.
All right, so working with the military population is actually a huge passion of mine, and I've studied that before coming out here to Boston. Given we work through VA hospitals, we absolutely have veterans having their brains donated to our bank. As I mentioned earlier, we're actually an umbrella for 7 different brain banks, and we have one specific for military personnel, which is our PTSD brain bank. But we are very interested in the different exposures to head injury that military service members are receiving. We're really interested in the differences between blast exposure that they're experiencing and the point loading forces that we're seeing in contact sport play, which is something I personally would like to pursue further. And more studies still need to be done to better understand that. And we do encourage more donations from military service members to better capture what CTE looks like in their brains as opposed to in athlete brains.
And just to quickly add on the clinical side, we have trouble characterizing what someone's going through when they're in the military. We don't know a lot of what someone's, enduring, if you will, with placebo exposure, with training. A lot of it is, one, kept secret by the donor or informant themselves, and two, we don't have the records necessarily to be able to access those. It's not documented well. There's a lot of gray to pour through to get to the answer. So we do try to request service records, but it is an arduous process. Anything in bureaucracy, but it is valuable, and we are making strides to obtain that information.
Yes.
So what is the incidence of CTE in the military population?
I'm sorry, say that again.
What is the incidence of the CTE in the military populations in the bank from the VA?
Yeah, do you know that? What is the incidence of CTA in the military servicemen in your bank?
It's not reported, but I would like to say that incidence is a tough word to use because if they're already passed, it's it's just prevalence, it's there or it's not. We can't follow them longitudinally and say they've gotten CTE because we can't diagnose it until they've passed. But currently we don't have data to support how many people have had military exposure and CTE, because we're currently working on projects that better ameliorate those exposures, and then we're able to speak on those cases themselves.
So I'm going to thank the speakers this evening. It is a tradition among Science Cafe to present the speakers with a Science Cafe mug.
Thank you.
So I'm Gunnar Riley, another member of the steering committee for Science Cafe. I'll remind everyone, first Tuesday of the month is Science Cafe, so we will be back here at the last round on October 1st for a talk about drugs that potentially could treat CTE and similar brain disorders. That's my physics speech for this. And again, I encourage everyone to stay and keep eating and drinking. Thank you to last round. And thank you again for a wonderful. You're off the hook, but if anyone has any extra questions.
Yeah, happy to hang around for a little bit if anyone wants to chat.